There were several handouts, I think, materials that the presenters sent in advance, referencing some of the programs they talked about today and some other background information, so you can take a look at those. So we realized we went through some of those presentations quite quickly, but we're hoping that it spurred a few thought bubbles in your brains, and if you have some questions for our panelists. Or comments from our panelists or the audience of your experiences or challenges, please step to a microphone. Microphone, please.
Small question. I just want
Can you go to a microphone, please? So that our
survey. Sorry.
Thank you.
Yes, I just wanted to know what was the parent survey that you implemented.
Sure, I want to turn this over to Deb about the survey.
Here's one.
So we're really just measuring what is a neighborhood social organization, what some people refer to as collective efficacy, but looking at informal social control, neighborhood norms, so actually surveying the entire neighborhood to get a representative sample around those neighborhood social processes. And then also asking questions about access to resources, resource availability, use of resources, and then particularly given a lot of things that are going on in Chicago right now, asking about encounters with police violence, those sorts of things. So it's again, a random sample across the whole community of about 600 adults in the community. Maybe more than that, I can't remember. We're just in the middle of starting to collect that data.
Kelly Kelleher from Columbus, Ohio, and I'm just curious, I thought in the middle of the method somewhere we might get some comment. One of the challenges is the state Medicaid directors, for example, right now had a recent meeting. The CMS folks, one of whom will be here later, were at a recent meeting. The American Academy of Pediatrics and the Children's Hospital Association, all of which said to the research community, as we start to look toward prevention and accountable care and other things, what should be our handful of metrics? And if we don't have common metrics, we have 1,000 programs, let 1,000 flowers bloom, but they actually want to tie accountability to metrics eventually, and I just wonder what we want to put forward as a community to those individuals and those groups.
Anyone on the panel want to address that question? Or others in the audience who might have thoughts?
I would love to speak to that point. And because I think that one of the things that we are all talking about in prevention is strength-based approaches and developing strengths and protective factors. And yet many of our archival measures are of problem behavior outcomes. And in communities of care and in developing communities of care, we said if we're going to prevent a problem before it happens, we have to address the predictors of that problem. And we know about risk factors, and that means we should be measuring risk factors. And some measures of risk factors are available in our big archival data sets, but a whole lot of the measurement of the risks that young people encounter can't be really determined unless you ask young people themselves. So one of the really exciting things about what Pastor Harris and Rodney have done is to really say to the community, we need to learn from our own young people about their experiences, both the risk factors and the protective factors that are here in our environment. And it's based on that data that we can then, as a community, make decisions about what we need to do differently. And so Kelly's question is a big, huge question. And I want to submit to you that I think just pulling together all the archival data sets that we currently have in America is not going to get us to the point that we have the data in local communities that we need to make decisions about what needs to be done to make this a less risky environment and a more protective environment for young people.
Patrick Tolan, University of Virginia. And I think one of the questions that Kelly's question, as well as what you and Jerry and Hendricks in particular were talking about, is this question of mediation analysis is a big term. because we know very, very little about the processes of these programs. And as we start to talk about trying to go to implementation, adaptation, common metrics, what we really are going to need to be looking for is something that says, here's how these programs work. Not here's whether or not I mean, it'd be good, we want to show the outcomes, but also how do we start to come to some common understanding of what these programs do and what they don't do. And we'll get into this a little bit more this afternoon, but I think that might be that's an area that seems to me that there's been very little good science. And so one of the questions for people who are talking about programs that they're starting and doing is how to really think about getting that mediation analyses and measurement in there. So.
Yeah, and I think there's a lot of commonalities in here. I was just trying to think of back at the time, Tony Biglin was working on this project in here about what are the community measures you would want to do systematically across the whole country. And I think those are the pieces that we have not yet stitched together. I think that they're really not quite there. I do think that these kinds of risk and protective factors that David was talking about are important in here. We do need to know how many people can come ready for elementary school, for example, ready to read. That's a huge factor in here in terms of predicting and developing across time. And we can do an awful lot if we know what that is to try and identify particular targets of interventions within communities before we do this one. That's just one simple example.
Building on your point, Pat, this has become a very important area of looking at mechanisms of change. And for years now, we have focused on mechanisms above the skin, attitudes, values, social competencies. And the field is now moving toward looking at mechanisms under the skin. Where does the intervention actually take root? Stress response is a very important mechanism that underlies risk for many youth. Emotionally dysregulated youth who engage in conduct disorder problems, and looking at various indices, starting with epigenetics, moving to neurocircuits, moving to hormones, moving to cognitions, and ultimately behaviors. So I think in the next 10 years, you're going to really see growth in this particular area. It's not the total picture, but it's a very important part of it.
Linda, did you have a comment?
Yeah, thanks. I just want to jump in. I also appreciate the nod toward looking at positive behaviors. I think that's one of the reasons why our leisure-based programs have been so positive, because people really do, the kids and the teachers and anybody really do respond positively. It's not based in something that's negative, so to speak. And we have done some mediation analysis. We have something coming out in Prevention Science. I think it's already published online, looking at whether health-wise affected the kids' perceived leisure opportunities in the community, and then whether that affected substance use and a couple of other substance use measures, and indeed it did for girls. And so we affected that, and then girls who had higher perceptions of perceived leisure opportunities in their communities had lower rates of substance use. And so we are trying to unpack those kinds of things. And that was, of course, our logic model. That's what we were hoping to happen. That's what's the theory behind the programs. Thank you.
Could I follow up? Actually,
Oh, I'm sorry.
yeah.
Related to this topic, and I'm not sure.
Well, I actually want to follow up on what David and Kelly said, and I think it's very resonant to this. Is that okay?
Please, yeah.
Yeah, I'm Dave Shern from Mental Health America and from NASHBID. And a colleague of mine who can't be here today because we're having our annual meeting, Nathaniel Counts, and I have been working together to try to develop a set of metrics that can be included and are in ordinary clinical practice that relate to healthy development. So there's an opportunity, I think this is exactly what Kelly's talking about. There's an opportunity right now over the next several months, actually, to suggest a series of measures that are responsive to the kinds of outcomes we want to achieve in terms of prevention interventions that could be implemented in pediatric practices. And as I understand it, that, there's EPSDT type measures, and this kind of fits into that framework. But if you think about sort of social emotional competency and indicators of healthy youth development, there's a paucity of measures there. And what Nathaniel has asked me to do on his behalf is to solicit from you all suggestions about measures that you would like to see included he will try to distill those and process them with this group and others and try to move those forward so we can actually start to get some traction around things that are important to us in the measurement headset that's used around quality improvement and quality management. And I think that's an important way that we can start to actually institutionalize the things that we're talking about. So if you're interested in participating, please see me and I'll give you the little matrix. My colleague is not under enthusiastic in terms of what he thinks we can achieve, but anything that you can help in terms of filling out this matrix around these sort of positive attributes of development, I think we can get into conversation in an important way.
Right, we'll encourage people to touch base
Yeah.
with you separately.
And I was actually going to go in that direction too. So thanks to David and probably to Tony behind me here. I think promotion and prevention are, Davis used to say, it's like two sides of a coin. So problems bring people to the table, but I think what we're really seeing in terms of engagement of communities and sustainability is that vision of what do we want for our young people, what do we want for our community. And so I think having those solid indicators is really going to be important. We can switch them around because they are like the two sides of the coin, but I think it's really important for us to be thinking in that direction.
Good afternoon. I just have a comment I'd like to make. As we begin to and continue to look at prevention science, I think it's imperative that we give full consideration to the social determinants of health, which play a key role in risk and protective factors, as well as the determinants of hopelessness, which plays a key factor based on culture. And in addition to that, it's important that we start to consider sex and gender differences in all of this work that we do if we want better outcomes, particularly for women or females.
Thank you. In any of your research, Linda, maybe in going across cultures in particular, maybe there's something you're
Yeah, we've certainly found, and we search for differences, especially in gender, and we found our programs work better for girls in most circumstances, especially in our first HealthWise program trial. We had 5 schools in the control group and 4 in the experimental group. We had 1 that was high implementing, which really got us into trying to understand implementation. But in the high implementing school where we found our best results, the results were much stronger for girls. And so trying to figure out why that happened culturally and what could be done to change that, I think is extremely important.
Thank you. Please.
Yeah, coming back to the measurement issue, David and Pat Mrazek and I published a thing, must be 10 years ago, on the value of assessments at the community level. And I want to build on something that Gary Belkin said, just to make this point, because he was talking about, the messiness and so on. But think about this from an evolutionary standpoint. We have variation and selection is the fundamental notion of evolution. Imagine that we never did another randomized trial, but that every community in America had accurate and timely data about the well-being of its children and adolescents. Just start with children and adolescents. And that each year, every community had a week where they celebrated and looked at the data and said, oh, this is improving and this is getting worse, and oh, what are we going to do about this, and so on. And there were no more randomized trials. I submit that would, at the same time, enable the selection of better and better outcomes. Now, I'm not advocating that we do that, but I'm just saying that to the extent that we keep our eye on the ultimate prevalence of problems in the population, that we will, and we are carefully measuring that, and we're feeding that back to people, and we're encouraging the kinds of conditions we need to ensure well-being, we will steadily improve. And the last thing I'd say is I turned 72 on Monday. How the hell I got this old, I don't know. But I will tell you, I'm listening to what's going on in New York City and what's going on all over this country and so on. We have made so much progress in improving human well-being, and I think it's accelerating. It's very exciting, and I might stick around for a few years.
That's a very good point. It's to not lose sight of what we have achieved so far. I think this will be our last question.
Happy birthday, Tony. and I sure hope you do. Stick around for a while. So I'm guessing most of us applaud the idea of this goal of common metrics. I think, like David and many others, that it's critically important to pay attention to protective factors in developing those common metrics. But there was a reference to doing this at a national level. Communities across the country, I think, indeed, that's the intent of the document that Tony was just referencing, and he imagined doing that. How do we do that? How do we develop the capacity? Where are the data systems infrastructures? How do we get there? So we get the measures, that can happen. That seems like a very viable goal. But then how do we apply them? How do we develop the systems necessary to do that systematically across the country so we can follow up on what Tony just suggested? Pregnant pause. Oh,
well, I do think one place that's a start of that is NISDA, and that's the SAMHSA surveys for households for kids and adults. And I think that's an important step in here. If there was a way to extend that, I think that would be helpful in here. But we've got a long ways to go.
Very big challenge, please.
If I may, as a public health person sitting here and written a lot on this, there are places to begin. And in fact, I feel this is a real core function of public health. It is one of the three: assessment. And CDC and the public health departments actually have plans that have done a lot of this. And there is in the MMWR recommended 10 things that you monitor at the community level. Granted, sometimes it's not all the protective factors, but if you could do community-based surveys like the BRFS at the community level ongoing, you'd have a lot of this as the beginning. And in fact, the Institute of Medicine did a report in 1996 called Improving Health in the Communities, where they laid out a lot of this. Again, a lot of the history gets lost, and I think we're crossing over different kind of disciplines. There is a lot of guidance there to begin with. What I feel is sad is the public health community has not been able to deliver. First of all, it is way underfunded, which is one of the key areas. There are states like Massachusetts and Utah who have done that. In Massachusetts, you could dial in and get any data you want free at any level, at the census level of all data, including educational data. And there are other models in California, et cetera. The United Health Fund does a thing yearly, which is at the state level. So if we came together collectively, there is a lot to begin with and a lot that has been recommended, but we do not have the political will to collect it. You need data at the community level, there's no question, to do some of the things we're doing. And in fact, some of this is also lost because it doesn't get to the publications based on my comment before about what the paradigms are to do it. And within health departments and the welfare departments, people don't have time to publish this. So again, I think we have a lot as a good beginning rather than reinventing the wheel. What I'm worried about is medicine is actually going to now start to claim this, and they're going to put the money on the table to collect it, and it's going to be what they want to collect in the name of population health, when really population health is public health. I know. But anyway, we have a lot to build on, and I could give a lot of articles and things to do that we're not talking about.
So I think this is a good stopping point for us. Not only are we out of time, but clearly this is not an issue we're going to tackle in the next 45 minutes, but it might be some good lunch discussion for folks to gather around. So I have just a few logistics things as a reminder. So now we're going to break for lunch. Now lunch is outside in the atrium. So please help yourselves, and we'll meet back here at 1:15. Thank you so much.